Good evening, everyone. Thank you for joining us and welcome to Anderson House here in Washington, D.C. My name is Andrew Allen and I am the Historical Programs Manager for the American Revolution Institute of the Society of the Cincinnati. The American Revolution Institute promotes knowledge and appreciation of the achievement of American independence, fulfilling the aim of the Continental Army officers who founded the Society of the Cincinnati in 1783 to perpetuate the memory of that vast event and to preserve the timeless ideals on which this nation was established. Those ideals, such as liberty, equality, freedom, civic responsibility, natural and civil rights, and the rule of law, have shaped our nation's history as well as other countries worldwide and are just as important and relevant today as they were at the outset of the Revolutionary War in 1775. Along with tonight's lecture, the Institute's work includes supporting advanced study, developing exhibitions and other historical programs and tours, advocating for historic preservation, and providing resources to classrooms nationwide that assist teachers, students, and scholars alike. Tonight's lecture features Dr. Ronald S. Gibbs of Stanford University discussing medicine in the American Revolution and is made possible in part by a generous gift provided by the Massachusetts Society of the Cincinnati. Disease was a major part of the everyday life in the American colonies, especially during the Revolutionary War. For every soldier dying of wounds in war, 7 died of infections, including smallpox, malaria, and typhus. Doctors were influenced by ancient medical thought and with the best intentions treated diseases with bleedings, leeches, and purges. Tonight, Dr. Gibbs explores the world of medical practice in the Revolutionary War by examining the various common diseases, forms of treatment, and other procedures that soldiers endured throughout that conflict. This program accompanies the exhibition, Saving Soldiers, Medical Practice in the Revolutionary War, now on view through November 27, 2022. Ronald S. Gibbs is a clinical professor and Knowles Distinguished Scholar at Stanford University. While attending medical school, he researched 18th-century medicine in London, for which he won the History of Medicine Prize upon graduation from the University of Pennsylvania. Early in his medical career, he served as a major in the Army Medical Corps at Walter Reed Medical Center in Washington, D.C., and was a professor and chair of obstetrics and gynecology at the University of Colorado. He has provided service to the National Institutes of Health, Centers for Disease Control, and numerous other professional organizations and medical journals. A nationally recognized expert on infections and pregnancy, as well as the current president of the California MAP Society, he has written numerous medical and historical articles, the latter being featured in the Journal of the American Revolution, Calafia, the Journal of the California MAP Society, and International Map Collectors Society Journal. His most recent work, The Long Shot, The Secret History of 1776, was published in 2020. Now, before I turn things over to Dr. Gibbs, a few housekeeping items are in order for those of you tuning in with us via Zoom. Following this evening's lecture, there will be a question and answer session. Please feel free to submit your questions for Dr. Gibbs using the Q&A function found at the bottom of your screen, and we will do our best to incorporate them with our live audience questions. Should you have any technical related questions or comments, those can be submitted using the chat function, and one of our staff members will be monitoring that and will do their best to assist you. Now, it is my distinct pleasure to welcome my friend, Dr. Ronald Gibbs.
Thank you, Andrew. Good evening to everyone. It's a great pleasure to be here, especially on the occasion of having this magnificent exhibit about saving the soldiers. I do want to especially thank Andrew for helping me with this presentation when we got an earlier version of it together a little over a year ago. So what was it like if you were a doctor in 1776 in the American colonies? Well, you would have been about one of 3,500 physicians, but the odds are you would never have set foot in a medical school. That's because over 90% of the physicians in the colonies at that time got their training by apprenticeships. These were informal, unregulated trainings at the bedside of another physician. Less than 10% of the physicians went to medical school, either in Europe or in the United States. but there were only two medical schools in the United States. One was called the College of Philadelphia, which was the forerunner of the University of Pennsylvania School of Medicine, my medical alma mater. That started in 1765. And the only other medical school in the entire colonies was one that became Columbia Medical School in New York, but that actually had to close during the British invasion. Well, practice really hadn't changed very much since ancient times, and it featured bleedings, purges, leeches, and vomits. Well, if you were a physician in the American colonies, there was a 100% chance that you would be a white male. The first African American to get a medical degree was James McCune Smith, but he didn't get his degree until 1839, and he had to travel to the University of Glasgow in order to get his degree. And the first woman to get a degree at an American medical college was Elizabeth Blackwell. She was actually English born and came to the United States. She was a social advocate, applied to every other medical school in the country, and was turned down on the basis of sex discrimination. And she was accepted only to the Geneva Medical School, which later became Hobart College. Formal nursing education in the United States did not begin until after the American Civil War, but women did play an essential role in hospital care. They carried out nursing duties, sewing, cooking, and cleaning. And if you were a physician, you'd never wear a mask. You'd never wear sterile gloves. You would never wear sterile gowns, because there was not very good understanding of how disease was spread. There were some ideas and basic observations about hygiene. We'll mention that a bit more. But the whole idea about modern concepts of disease would be 75 to 100 years off. To understand the setting of disease in the colonies, we have to begin by a look at a map. And this is a 1771 map of the British colonies. The entire population in the 13 colonies numbered only 3 million. And nearly everyone lived on small villages and farms. The largest city, my hometown of Philadelphia, had a population of only 30,000. The next largest city was New York with 20,000, and the only other cities with a population over 10,000 were Charleston, South Carolina, and Boston. So nearly everyone lived in the rural parts, and hardly anyone traveled more than 30 miles from home during their entire lifetimes. Even so, disease was a part of everyday life in the 18th century. When we begin communications now, we begin saying, "I hope you are well." Well, that goes back to the 18th century when you really did hope that someone was well. The average lifespan for men was late 40s or early 50s, and the average lifespan for women was even less due to complications of childbirth. People had large families, there wasn't very good contraception, but they also knew that there was a horrific early infant mortality, a staggering 25% in the first year of life. In Jean Abrams' 2013 book about health during the American Revolution, she makes this seminal statement: disease was a constant fear embedded in the American psyche. And when war broke out, things got even worse. The effect of great masses of people. During the 1776 campaign in New York, the combined strength of the British and the American forces was 50,000, greater than the total population of New York and Philadelphia put together. There was crowding. There was exposure to new diseases for many people. There was poor sanitation. There was poor diet, particularly in winter, lack of fresh vegetables and fresh meat, and there was exposure to inclement climate. So wartime conditions created a setup for disease. Nevertheless, when you look at paintings from the American Revolution, such as this one of the British line charging up Bunker Hill in June 1775, or this one of the British line making it in to the earthworks at Bunker Hill, you might conclude that most of the injuries to soldiers was due to wounds. Look at the muskets, look at the swords, look at the bayonets, and you can actually hear the cannon shots in the background. Well, it was just the reverse. Disease was responsible for 70 to 90% of the deaths among the soldiers. And this was a combination of military life, the state of the technology of medicine, and the state of the technology of war. So during the American Revolution, there were really only few large battles each year. The weapons were relatively slow firing and had relatively short range. And injuries that did occur were mainly stabbing or cutting injuries from bayonets or swords, gunshot wounds, and occasional cannonball injuries. It's estimated that almost 250,000 American soldiers served in the Continental Army, and another 145,000 served in the militia. But the estimated number of killed in action was 7,000, and over another 20,000 died of disease. Now, if you compare that to the American Civil War, where the armies were much larger and casualties north and south occurred among Americans, there the death toll was 600,000. So what were the diseases that were the biggest threats? Well, a huge one was smallpox, and this occurred in outbreaks throughout the war. But day in and day out, more common diseases included a disease known as typhus today. But in the 18th century, it was called camp fever or jail fever or ship fever or putrid fever, owing to its occurrence in crowded conditions. Malaria then was called intermittent fever or remitting fever or quotidian or tertian fever, depending upon the fever pattern. We now think of that as a tropical disease, but malaria in the 18th century in summertime made its way into the middle colonies, including Pennsylvania and New York. Dysentery was common. Dysentery includes many modern diseases, but then it was lumped as called the flux, a diarrhea. And then there were many respiratory diseases, including pneumonia. Venereal diseases have always been part of armies. And at that time, syphilis and gonorrhea were not really distinguished from each other, but syphilis was called the large pox to distinguish it from the smallpox. And in the English army, it was called the French pox, and in the French army, it was called the English pox. And then there were many skin conditions owing to the unhealthful conditions, and those were largely called the itch. Well, I have some photographs now, maybe not particularly good if you've just had your dinner, but I want to start with this photograph of an individual who has confluent smallpox lesions. Smallpox was known since ancient times and was characterized by headache, by malaise, by high fever, and the typical pox rash shown here. It spread rapidly, and had a mortality of somewhere between 15 and 60%, depending on the outbreak. We'll get into the marvelous story about control of smallpox in just a few minutes. This is the rash of a disease called typhus, the jail fever, ship fever, and so on. And this had symptoms of chills, headache, sore tongue, and fever that was often high, 107 to 109 in fatal cases. And this spread in crowded conditions. And it was spread by the Typhus louse. The louse was the vector and spread a type of bacteria called rickettsia that caused the disease in crowded conditions. The mortality rate of typhus, if untreated, is high even today, but today this is a disease which is rapidly cured by a common antibiotic called doxycycline. And here is a modern microscopic photograph of the parasites that cause malaria inside red blood cells. The malaria is spread by the Anopheles mosquito. This is a night fever. But in the 18th century, the cause was not known, although there was a clue to it because malaria comes from ancient Italian, meaning bad air. And the ancient Romans did have a clue that this could be spread by bad fumes arising from swampy ground. And as we noted, this was spread in summertime up to the middle colonies. Here is a typical pattern of fever for someone who had malaria, and this coincides with the life cycle of the parasite that causes malaria. It is one of the most dramatic and characteristic presentations in modern medicine. Malaria still occurs in the United States. When I was in the medical corps, up at Walter Reed, just up the block or so. I saw many cases from Vietnam. And today we even see cases among travelers who fail to take or inadequately take their prophylactic medication. So we have many drugs that will treat malaria. And during the initial part of the COVID-19 outbreak, there was mention of hydroxychloroquine, a drug used to treat malaria, but that turned out to be a not very good, in fact, a totally ineffective treatment for COVID-19. And then the dysenteries often are self-limited, but the disease called typhoid fever can be fatal. Today, that's readily diagnosed and is treated with a variety of antibiotics. And in fact, there is a vaccine to prevent that. Fortunately, there were no outbreaks of a dread disease called yellow fever during the American Revolution. Well, now having gone through the diseases, we want to ask the question, what was 18th century medical thinking all about? And why did they have all of these strange diseases and treatments like bleeding and purges and so on? Well, it was actually all internally consistent. Medical thought had not really changed from ancient times, and the prevailing medical thinking was called the humoral, not very funny, but the humoral theory of disease, meaning that disease was caused by an imbalance of the body humors or the bodily fluids. And given that premise, it would make sense that you would restore health by rearranging the fluids, taking blood off, causing a diarrhea, causing a vomit, having leeches, causing blistering. Well, modern medicine really didn't get going again until the middle of the 19th century in Central Europe and in England as well. Well, with no knowledge about bacteriology or virology, 18th century physicians were really handicapped about what to do. But there were early observations about the importance of hygiene and cleanliness. A prominent senior military British surgeon by the name of Dr. John Pringle, mentioned in the exhibit, wrote a treatise about how to dig latrines, and orders in the American Army punished someone with 5 lashes if they were caught relieving themselves not in the latrines. And Dr. Benjamin Rush, who we'll talk about in a minute, wrote a pamphlet in 1778 called Directions on Preserving the Health of Soldiers. And about 2 hours ago, I had the thrill of actually seeing that pamphlet in the exhibit next door. Well, let's mention a bit of a side issue, and that is the bleeding of George Washington. You may have heard that George Washington was bled to death by his doctors. In mid-December 1799, George Washington, a very distinguished horseman, went out for a ride in Mount Vernon on a snowy, bitter afternoon. He returned to his home and shortly began to have evidence of a very severe sore throat. Today, that would have the jaw-distinguishing term of acute necrotizing epiglottitis, a very severe sore throat, probably caused by the Streptococcus bacteria. He had a team of 3 doctors who were taking care of him, and with the very best of intentions, they bled him. They bled him of nearly 2.5 quarts of blood over 4 bleedings over 12 hours. It was about 40% of his estimated blood volume. Surely that didn't help the Olympian character of George Washington, but I don't think it killed him. In 1999, there was an account of George Washington's death in the prominent New England Journal of Medicine, and he basically died of respiratory obstruction. And the bleeding was almost certainly not responsible for his death. And the sad part is, if penicillin had existed back in 1799, he would have been very quickly cured. Well, let's take a look at some of the approaches to treatment. Down at the bottom, you see these lances. There's a set here, a set here, and a set here. These were used for multiple reasons, mainly to open a vein at the time of a bleeding. A tourniquet would be applied, the vein would be slit, and into a rather elegant pewter bowl, a volume of blood of maybe a quart or so would be let at one time, and this was often repeated. And then the idea would also be extended to restoring the bodily fluids by using these wriggling leeches. Well, these leeches, my wife Jane just shuddered. Maybe someone else did also. So these leeches would be applied in a set over the area where there was the inflammation. If you had a pneumonia, you'd get it over your lung. If you had abdominal pain, or you would get it over your abdomen. An infected wound, you'd get it over the wound. And these would swell up to multiple times by sucking the blood out, and they'd be removed, and multiple courses of leeches might be applied as well. Well, what were other medications that the 18th century physician had that might in fact have been useful? Well, there were useful medications for pain. There was an opium derivative, and there was laudanum. And then there was a treatment for malaria that was called either cinchona, Jesuit's bark, or Peruvian bark. and this contained quinine, and that really was effective. And then there is the story of the variolation or inoculation for smallpox, which we actually have a video of. But these medications, even when effective, were in short supply. There was not enough in North America to support a war effort. Many of the apothecaries were loyalists, and even the apothecaries who were patriots were often unwilling to take the nearly worthless Continental currency. So the American army was always running late in order to get a supply for their medical chests, and had to rely upon scrounging and privateers and supplies from France and other European nations. Now, here's a picture of the cinchona bark itself. It was actually found by Jesuit priests in the Western Andes of South America in the 17th century and introduced into Western Europe. But there was hatred, religious hatred between the Protestants and the Catholics. And Protestant physicians hated the Jesuits so much that they refused to accept the worthiness of the bark. And debates ravaged, and there was delayed uptake. Well, now we want to address the issue of inoculation. Just before we start, Libby. So we're going to show a couple of minute video from the John Adams series. This will be a dramatization of John Adams' wife, Abigail Adams, receiving inoculation from, I believe it was Dr. Thomas Bulfinch of Boston. So the idea was to create a mild infection. We'll show how that is done, and thus preventing you lifelong from the life-threatening problem of smallpox. Remember, natural smallpox had a mortality of at least 15 to up to 60%. There was still slow uptake in the smallpox inoculation because it made everybody ill and had a small but real mortality of about 1%. And we'll narrate this as we go. Ready, Libby? Okay, here is Dr. Bulfinch walking out to his cart, where you will very shortly see a smallpox victim, very moribund. These are so here is the victim still alive, but almost with confluent smallpox. Dr. Bulfinch is incising the blister and taking some of the pus and putting it on a glass plate. Now he's going to come inside, and you will recognize the actress Laura Lindsay playing the role of Abigail Adams, giving a brave smile to her children. Dr. Bulfinch makes a scratch with a lancet in her arm, and then he takes a small amount of the pus from the fresh pustule and spreads it into the wound. So everyone who got inoculation got ill, sometimes for a period of weeks. Mortality was 1%, but much, much less than the mortality of the natural disease. Well, with smallpox, such a scourge, was it used in the armies during the American Revolution? Well, the British Army began to use inoculations in about 1750, but it was not widely used with its troops in North America. And during the British occupation of Boston in 1775, 1776, there was an outbreak of smallpox and many British soldiers got it. Americans were more susceptible to smallpox because they lived in small villages and because they lived such rural lives. And it was not until 1777 that Congress and George Washington had the first mandate for inoculation against the smallpox. But then, as we've seen with the vaccination story with COVID, there was great debate among certain segments of society, certain segments of the military about taking it. Well, now I want to go on a very short detour to tell you about one of the great stories in medicine. This is Dr. Edward Jenner, a country English doctor, and his introduction of vaccination in 1796. This replaced inoculation. So Dr. Jenner made the observation that his milkmaid by the name of Sarah Nelms had a mild disease called cowpox on her arm. And the cowpox is related to smallpox. And cowpox and smallpox are related to the disease making headlines today called monkeypox. Edward Jenner recognized the cowpox on the hand of Sarah Nelms, and she was completely immune to getting smallpox. A great observation on his part. Then he carried out an experiment, and he took an 8-year-old lad, the son of his gardener, his name was James Phipps, and he inoculated James Phipps with cowpox. And then he intentionally exposed little James to smallpox. And little James was immune. This was 200 years before the notion of informed consent for medical research, but this carried out by the ethical principles of the 18th century. Edward Jenner becomes known as the father of modern vaccination and makes one of the hallmark discoveries in the history of medicine altogether. So let's talk about battlefield surgery. Well, with no anesthetic and really no concept of antisepsis, of sterilization, battlefield surgery was necessarily limited. There were amputations, there were treatments of gunshot wounds, there were stabbing wounds from bayonets and swords that could be dealt with, and then for head wounds, there was a treatment called trepanning. Well, the indications using the medical term for an amputation would be wound of a joint, repeated abscess, or shattered bones. An accomplished military surgeon could carry out a leg amputation in 3 minutes. And because no antisepsis was used, almost all amputations became infected, and pus was so common that it was thought to be part of the normal healing process and called laudable pus. These are two pictures of 18th century medical kits, and I will just point out that to carry out an amputation, a surgeon would take a tourniquet, wrap it around the limb, begin with a large curved knife, and cut down through the skin, the subcutaneous tissue, the tendons, and the muscles, have his assistant retract those, and then with a saw, looking like you could get it at any of your neighborhood hardware stores, would cut through the bone. A few large vessels would be tied off with ligature, a skin flap would be wrapped around the stump, and it would be dressed. The mortality of an amputation would be at least 50%, And if it were carried out when gangrene had already set in, it would be almost 100%. Gunshot wounds were difficult to be taken care of because the ball could have a maddening course through the body. But the idea would be to use a probe like this one to reach in and remove the ball. Bayonet or stab wounds of the chest or the abdomen were almost always fatal, and head wounds were usually fatal, but there was an operation called trepanning or trefining, meaning that a circular disc of skull bone would be removed if there were bleeding or infection in the head inside the brain. And this would actually be helpful by relieving the pressure. And now we're going to go to our second video. This is from the series Master and Commander. This is on shipboard. The crew is looking, and here is the trepan. It's a circular saw dug into the skull to remove a circular disc. And then just hold fast is the encouraging word. And here is the sailor with the head wound. Needless to say, with such limited treatments and no underlying treatment for the bleeding or infection, most head wounds were fatal as well. Let's say a few words about the hospitals. Well, the British had been fighting wars almost nonstop for decades, and they actually had a good system of organization. They had their general hospitals, which were staffed by good physicians, supported by apothecaries, cooks, nurses, and other commissary staff. And then there were the regimental surgeons who were supporting their regiment of about 700. In both the hospital, the general hospitals, and the regimental hospitals, there were surgical assistants called mates. The American Army was organized in a very similar fashion, but loosely so. And the general hospitals were staffed by good physicians. This happens to be the Birmingham Meeting House at the Brandywine battlefield. And at the time before the battle, it was used as a general hospital. The regimental hospitals in the field were set up wherever they could be, and a tent or a small building or a house. Towards the middle of the American Revolution, convalescent hospitals were set up, and this one is called the Yellow Springs Hospital around the time of the encampment of 1777, 1778 at Valley Forge. There were about 10 of these, and they were sizable, having several hundred patients. We can't conclude unless we talk about some of the physician leaders. The medical department got off to a bad start. Congress gave the medical department authority over the general hospitals, but no authority over the regimental hospitals and the regimental surgeons. Their authority went to the states that gave rise to them. And then things got worse. Pictured in the left panel is Dr. Benjamin Church. Benjamin Church was a prominent physician in New England, and he was the first chief physician. But he served only 3 months around the encampment around Boston in Cambridge, Massachusetts, because he was found guilty of colluding with the British, sending messages to British General Thomas Gage in exchange for money, in exchange for gold. He was jailed in late 1775, and then for some reason in 1777, he was allowed to leave jail, get on a schooner, and sail off to the Caribbean. But the schooner was lost at sea, and he was never heard from again. Good riddance to a bad actor. Now, Benjamin Church is not to be confused with the distinguished physician on the right, Dr. Benjamin Rush, who we've already mentioned. Benjamin Rush was born in the Philadelphia area in 1745. He got his medical education at the University of Edinburgh in Scotland, and then gained experience in London and Paris. When he was there, he got to meet everybody. He met prominent physicians, William Hunter and John Pringle, who we mentioned. He met men of letters, Dr. Samuel Johnson and Oliver Goldsmith. He met the painters, Benjamin West and Sir Joshua Reynolds. And then he returned to Philadelphia at the young age of about 24, where he became the first professor of chemistry at the medical school in Philadelphia. There he continued to make connections. He knew Franklin well. He lunched with Thomas Jefferson. He knew George Washington, and he collaborated with Thomas Paine in writing the pamphlet Common Sense. And oh yes, he was a signer of the Declaration of Independence. He was the fourth youngest member of Congress. But he was forward thinking. He was a champion of health. He promoted hygiene, as we mentioned. He was the champion of humanitarian treatment of the mentally ill and goes down as history as the father of American psychiatry. He was in favor of abolition of slavery and the education of women. During 1777, 1778, he was the Surgeon General of the Middle Department in Pennsylvania, New Jersey, and New York, and he was at the battles of Trenton, Princeton, and Brandywine. He did have rivalries with John Morgan, as we mentioned, and he did believe in bleeding, but he was a truly remarkable man, rising in many cases above his time and place. Now, not all of the fighting took place on the battlefield, and we want to mention the rivalry between these two doctors, Dr. John Morgan on the left, who was Director General after Benjamin Church, and Dr. William Shippen, the Director General, to follow him. Now, these two physicians had a lot in common. They were both from Philadelphia. They were born a year apart. They both got their medical education at the University of Edinburgh, and both envisioned a new medicals, the first medical school in North America. But they were very different, and by God, they hated each other. John Morgan followed Church, and he was hardworking, he was intelligent, and he was an outstanding physician, but he was arrogant and he was egotistical. The general hospitals were badly in need of organization, but John Morgan quarreled with everybody. He quarreled with the regimental surgeons over authority. He quarreled with William Shippen. He quarreled with Congress over support and authority. And finally, Congress had enough. And after about a year, they fired him in early 1777. William Shippen brought improved organization to the medical department based upon the British model. Shippen himself was very different. He was affable, he was well respected, and he was charming. But even these characteristics were not enough. Now it was John Morgan's turn to turn the tables and to attack Shippen, and Morgan aligned himself with Benjamin Rush. They made charges against Shippen of fraud, irregular accounts, and neglect and conduct unbecoming an officer and a gentleman. Finally, in 1780, all of this griping led to William Shippen being court-martialed, and the outcome was that Shippen was exonerated, but he resigned his commission and his reputation was tarnished. So the whole medical department in the Continental Army had a pretty messy leadership. First director colluding with the British. Second director fired after a year. Third director court-martialed. And the last topic that we want to mention is doctors as battlefield heroes. And there are three who I wish to highlight. Joseph Warren is also mentioned in the exhibit. Joseph Warren was a very prominent Boston physician, and he came from a very prominent Boston medical family. He was a leader of the Patriot cause, and on the night of June 16th, anniversary tonight, and June 17th, he took up his arms and went to the redoubt at Bunker Hill. In the last attack by the British coming into Bunker Hill, Dr. Joseph Warren pays the ultimate price, is shot in the head and then stabbed to death by the British. The second physician we want to mention is Dr. Hugh Mercer, a brigadier general. Hugh Mercer was originally from Scotland, came to America, practiced medicine, but then during the French and Indian War was a line officer, became a friend of George Washington, served in the Continental Army, and at the Battle of Princeton on January 3rd, 1777, was shot, it is alleged, right by where this tree is. He was mortally wounded, lingered for 10 days in this bed at the Clark House, and then he died also. And the third battlefield hero is Dr. John Haslett. Now, John Haslett was a native of Ireland. He settled in Delaware, and in 1776 commanded the 1st Delaware Regiment. He was at Dr. Hugh Mercer's side. Hugh Mercer gets shot in the chest. Immediately after that, a British bullet comes and shoots Haslett in the head, and he dies instantly. So these three physician heroes all paid the ultimate sacrifice and are worthy of mention. And I want to conclude this address by telling you about this work of fiction. It's called The Long Shot. It was published 2 years ago, and it is called The Secret History of 1776. It's an alternative history, and it asks, what if during the early precarious years of the American Revolution, George Washington gets shot by a British sniper? Well, there's no whisper that George Washington was ever shot, but he was thrilled by battle. He was often leading from the front, and it is actually quite plausible that George Washington could have been shot. Now, having wounded the Olympian character, it's my job to save him, and I create a very forward-thinking physician by the name of Dr. Alexander Grant. And for the rest of the story, I hope you'll be intrigued about this. And at this point, I want to say it's been a great pleasure to ask this and see if you have questions or comments you'd like to make. I just happen to have lugged a few copies of the book all the way from San Francisco, and we'll take questions from the floor. Please, Andrew is going to go around with the microphone so our large virtual audience will hear it.
Thank you. Excellent talk. During the amputations, did they use alcohol as a painkiller, and would that have been effective?
I'm sorry, could you repeat that?
Yeah. During the amputations, did they use alcohol as a painkiller, and was that effective?
Well, there was there was no anesthesia, but there were laudanum and opium. Alcohol was used and restraint was used, and often a wooden rod would be placed in between. That's why speed was really of the essence. And often the surgical patient would pass out. Yes, another question up front, Andrew.
Yes, thank you. How do you compare the Civil War medical procedures against what happened during the Revolutionary War?
Okay, comparing the Civil War versus the American Revolution. Well, as I mentioned, the mortality in the Civil War was 600,000, 100 times greater. That was owing to the much larger sizes of the army. The largest army George Washington ever had was 20,000. The Union would have armies 5 times that size or greater. And then the technology of warfare was different in the 19th century versus the 18th century. But the tactics were not very different. So there was still charges and ranks moving up. The status of medicine was advanced somewhat. Anesthesia had been introduced in the 1840s, but there really wasn't much anesthesia that could be used during battlefield surgery. Antibiotics were another 100 years off. There was an idea of cleanliness, and there was the United States Sanitary Commission. So things were better, but it was still another 75 years before things really made a giant step. Thanks. Other questions?
I just have a question about fiction, since you brought in those two TV clips. Have you seen the Nick and the Nick TV show about a hospital in 1905? Have you seen that?
I'm sorry, I'm having trouble hearing.
Because you showed those two clips of TV shows, I'm just wondering if you've seen the TV show called The Nick about a hospital in 1905, and if you had any.
I haven't. In general, my wife will attest, I hardly ever watch medical shows because of how distorted they make things. And
Well, I recommend it. It takes place in 1905, so it might be up your alley. But
okay, well,
it's basically Squid Game in real life
it's set where?
in New York.
Okay, I will follow that up.
Sure, I have a question. So you were mentioning there's this technique of bleeding to help an ailment. Was there ever any evidence of that having any effect at all? What was the outcome? Did that ever actually help
I'm sorry?
patients?
Any evidence of?
The bleeding, I think it was called bloodletting, is the technical term that they used back then, when they would lance at an artery. Sure. When they would bleed somebody with an infection, did that ever help the patients?
No, the thinking was leading to the laudable pus, thinking that pus was part of natural healing. Well, it's part of infection, but no, that would generate an immune response, but it would not be helpful. Okay.
Were there any areas that the British were better at than the colonials in terms of medicine?
The British had a major disadvantage in that everything that they brought had to come from England. So so that meant a 4 to 6 week transit across the Atlantic. But they were, in general, better supplied with medical chests. They did have an established medical cadre because they had been fighting for decades in Europe. The British also knew about wars in North America, so from the French and Indian War. So they did have certain organizational and supply advantages. Their troops also probably were more likely to have received inoculation from smallpox, but they too suffered the same way from the common diseases, malaria, typhus, some smallpox, dysentery, and so on. Thank you.
Were there any plants that are native to North America that form the basis of useful
I'm sorry, I'm
treatments?
just having.
Yeah, I can speak louder. Were there any plants native to North America that were formed the basis of useful treatments?
What the question was there racism in treatments? Well, no,
Plants. Native plants for medicine. Native plants.
Oh my gosh, that's much better. Native plants for medicine, yes. The cinchona was the bark. They were beginning to experiment with a drug called, with medication called digitalis from foxglove. That plant came along. Many of the drugs used to cause a vomit or a diarrhea were botanicals. So rhubarb and so on. So yes, there was a listing of these that had been accumulated, but by and large, many of the things that were used were not very effective. Sorry.
You mentioned a bunch of diseases. What about cholera? Was cholera a waterborne disease? Was that prominent?
Yeah.
during the-
Cholera was not recognized as an independent disease in the revolution. About 75 years later, in the Crimean War, cholera was a big problem. But given the state of observation and laboratory medicine at the time, it was not distinguished independently. But it did become a much bigger problem like during the Civil War and the Crimean War.
What were the major lessons learned after the war that may have changed medical practice?
Mary, I think the most likely one was the importance of hygiene. But all of the real advances were predicated upon advancement in basic medical sciences, microbiology, physiology, and that again got started much later.
Hi, you mentioned most people were living a very rural existence. I'm guessing most people had animals. Was there a lot of communication between veterinary medicine and human medicine, or learning going back and forth?
I really don't know the organization of veterinary medicine in the Americas and when it actually got formalized. I'll have to check that. I don't know. Does anyone know? No. Okay. Well, we all have a homework assignment. I imagine that. Well, with nursing education after the Civil War, I'm sorry, I just don't know when the first veterinary school was open, and somebody must have their device. Maybe they could shout it out for us.
I guess I'm wondering, people must have been working hard to keep animals alive all over the country, and did anyone, kind of use that to, if you were a country doctor or whatever? Okay.
Yeah. Okay. Others? Do we have some nice?
Yes, we do
calls
have
coming?
some on Zoom here. We've got quite a few. Let me just scroll to the top here. So one question is, in comparison, how did life expectancy in the colonies compare with that of their contemporaries in England and the
I'm
rest?
sorry, Andrew.
Sure. In comparison, how did the life expectancy in the colonies compare with that of, say, England or the rest of Europe?
Yeah, this was a tough time to be alive, and exposure to disease was common. And I think it was probably stratified depending upon social class. So I think if you were poor in England, you had a very short life expectancy. If you were more privileged, it was better just by what we now call social determinants of health. I don't have the exact figures, but I'd be surprised if it were very different. Good question.
Another question was the concept of triage facilitated during the receipt of the wounded.
Okay, yeah. Well, triage today is a very important part of emergency medicine. It's a very important part of a military medicine. And by triage, it means that you take the wounded or a mass casualty, and divide them into one of three cases, one of three divisions. The first division is someone who has a minor illness and will get better, but doesn't require any real major emergent care. So that would mean keep them warm, slap a dressing on them, and come back and taking care of them later. The second would be those who have such severe illness that no matter what you do for them, they're unlikely to survive. And those individuals would be triaged to comfort care and let them expire. And the third would be those individuals who have remediable wounds, remediable illness, but who require something emergent. And so that is why we come to triage, the French word, the three different areas. But that concept was not well developed at the time of the American Revolution, not in any formal way. In general, there was a distinction, and officers were given the priority.
Question about scurvy. We know that scurvy was well known in naval service. Was that also a problem for land-based troops?
So actually, in the exhibit, there is a Royal Navy surgeon by the name of James Lind, who identified the course of the cause of scurvy. He identified this as being a lack of citrus fruits, and this would come out among sailors and shipboard individuals who would be on voyages over 4 to 6 weeks. He actually is credited with doing the first clinical trial in the history of medicine by giving limes to British soldiers, and hence the name limeys. Scurvy was recognized, and the problem with scurvy could have been a problem, particularly in wintertime encampments, in the absence of fresh fruits and vegetables, but much more of a problem on shipboard.
And another question, when people grew herbs in their kitchen gardens to help with ailments at home, was that something that the armies would forage for to help common ailments and replenish their stocks?
I'm sorry.
So when people grew botanical cure, or for medical purposes, in their kitchen gardens to help with ailments at home, was that something that armies would forage for on the move?
Yeah, in small quantities, yes.
All right, I think we will we'll end it there. Dr. Gibbs,
Okay, we'll
yep,
turn it
thank
back
you.
over
Yep.
to Andrew.
Right, I'll give everybody about 5 minutes to call their doctor and thank them. Thank you, Dr. Gibbs, for being here to speak with us this evening. I think we all have a much better appreciation for modern medicine and science now. And please feel free to come and talk to Dr. Gibbs about his book or anything after this lecture has concluded. But before we do that, I would like to invite you to visit the events page on our website, where you can learn more about our upcoming historical programs, which our next one is going to be held tomorrow here at Anderson House at 12:30 p.m. Eastern Standard Time. Right back behind us in the original library. And that is for a lunch bite featuring the Institute's Deputy Director and Curator Emily Parsons, discussing Dr. James Tilton's Society of the Cincinnati Eagle Insignia and his 1813 medical treatise, both of which are on display in our exhibition, Saving Soldiers, Medical Practice in the Revolutionary War. And if you would like to speak to the curator of that exhibition, she is in the audience tonight, Ellen Clark. Told you I'd always give you a plug while you're here. So there you go. Registration to attend both in person and virtually is now open as for that, as well as all of our other future historical programs. So with that, thank you again, Dr. Gibbs, for joining us this evening. Thank you all for joining us here at Anderson House, and thank you for joining us virtually on Zoom, and all of you for the continued support of our mission. So until next time, wish you all a great evening, and thank you and take care.